Welcome back. Hope you got up and moved around a little bit. Again, the importance of keeping active, not staying sedentary. We certainly don't want to increase your risk while you're sitting with us this morning. So thank you for coming back to join us for the rest of our morning here. And I am delighted now to introduce, again, my friend and colleague, Dr. Judy Garber, the Chief of the Division of Cancer Genetics and Prevention at Dana-Farber. And she will talk to us this morning about breast cancer genetics and prevention and what's new in clinical trials. So thank you, Judy, and welcome.
Thank you, Terry. Let's see if I can pull this off. As usual, it's always a question. Oh, and I apologize for the dog. I can't seem to do anything about that either. So is the view okay?
Yep.
Okay, great. So let's talk a little bit about genetics and prevention. Hold on one sec. Let me close the door. We'll hope for the best. Okay. So I thought we would do genetics, just a brief review, and then go on and talk about the clinical trials in prevention that are either offered now or in development and soon to be offered in the BPREP program. So we'll all remember that genes are made of DNA, and DNA is organized into chromosomes in the nucleus of the cell. And this is a picture of a cancer and a little joke that cancers are full of mutated genes, altered genes that are not functioning normally. So how do we go from cells that are totally organized in their chromosomes and genes to cells that are so disordered as cancer? So just as an example, an illustration, your chromosomes don't exactly look like this. They don't come color-coded. They do come with stripes that match up, and they do come with different sizes of the short arms and the long arms. So you can actually organize chromosomes when you need to. But generally, if you have a mutation or an alteration, we call them variants these days, in cancer susceptibility genes that increase your risk of breast, ovarian, or related cancers, the chromosomes themselves look fine. You can't really see this. And in there with the yellow arrow, I've just indicated that there might be one of these variants, but you couldn't really tell by looking at this diagram, and you can't really tell by looking at the chromosomes themselves. This is like a typo, a little change in one, sometimes just one DNA letter, sometimes more letters, but they lead to a change in one of those 25,000 genes Terry mentioned, and you can't really see it unless you're looking to read it with technology that reads the DNA letters. This is an actual picture of a chromosome. It's called chromosome painting, which is done. And these pictures that you see, certainly these are grouped of, this is a male, or this actually is a female. There's no Y chromosome. But these others are not paired, and they have all different colors. And that's because in this cell, which is from a tumor that's missing its BRCA2 genes, both of them, it's allowed all kinds of mistakes to be made when the cell's been dividing. And you can see why a tumor that has this kind of abnormal chromosome structure, and therefore abnormalities of the genes underneath, would not behave in a normal manner. The thinking about this came from actually mathematicians. Alfred Knudsen and Louise Strong had a hypothesis. How could it be that in some families cancer seemed to cluster? Was there really inheritance of cancer? And this was actually done before there was molecular biology to help us read the genes and give us all this genetic testing that we do these days. But their model said that, let's see if I can make this work, that in normal people, all of us are normal people, but in people who don't have an inherited alteration in a gene that confers cancer risk, the cells are normal. But sometimes there's a mutation or a variation, an alteration in the gene that's acquired as the cell is reproducing itself. And our cells are obviously reproducing themselves all the time. We have new skin cells, new blood cells, new cells lining the mouth and GI tract. Minutes every day, they turn over all the time. So they could make mistakes, but there are actually a lot of systems to keep them from doing that. Still, we can be exposed to environmental factors, or cells just might make a mistake that doesn't get fixed, and there is a variant. If a second hit comes in the same cell to knock that, to alter that variant, then a tumor could develop. And of course, tumors develop all the time. Cancer is a common disease, and most cancer occurs more frequently as you get older. So there's time for that to happen. If you're someone who's born with an alteration or variant in one copy of one of the cancer susceptibility genes, that's in all the cells. That's why, even though you're interested in breast cancer risk, for example, you can do a blood test to look for a genetic change. You don't need a breast cell because all the cells in the body contain that variant. But it's a lot easier, as you can see, to acquire one more hit than two hits in the same cell. So this is the second hit phenomenon. And this is why we inherit risk of cancer, but not cancer itself, most of the time. And most of the genes that turn out to give risk of breast cancer in particular, but ovarian cancer, pancreas cancer, prostate cancer, other cancers, are involved in making sure that the cell doesn't make mistakes when it's reproducing its DNA. So we call these DNA repair genes. These are the ones that go through, detect an error, fix the error, and let the cell go on and divide. Colon cancer genes as well. Not so much the genes that are structural, the genes that code for hair or hair color, although for me, hair color is now a chemical activity. What kinds of mutations are there? So what's a mutation is just a change. And you can see that a very subtle change can have a big effect. So here's wild type, we call it, or the regular code, which is divided into 3-letter words, actually. And here we have a sentence: the big red dog was fun for the boy. If there's one little typo, and M gets stuck in the wrong place, everything is okay, but until the M, and everything after is nonsense. It doesn't make sense. And generally, this part of the gene is not made into protein, and only this little piece is there. And you can see that that's unlikely to be able to do the whole job of a gene like BRCA1 or 2. Here, there's a missing couple of letters. So the O and the G of dog are gone, and everything sort of moves over, and you get the same kind of nonsense here. And you can just have a subtle change, like a typo. So this was a red dog, now it's a rad dog. So is that very different? Well, probably there's not that much difference between red and rad dogs, but other letters you could see would have a much bigger effect on the gene. And sometimes that change comes and it introduces what's called a stop codon. So instead of making the whole gene, you only make part. So these are subtle things that can be found, but now they can be seen on the genetic tests that we do, where the letters in the gene are read and they look and compare to the wild type or the normal sequence. Variants, and that's what everybody, that's the formal name, we all still kind of call them mutations, but the variants are classified then. Are they guaranteed to have an adverse effect? Most likely they do. They're totally benign. They're just typos. It doesn't matter. They're likely benign. Or this annoying classification we often get that says it's a variant of uncertain significance. They're not sure, and it will take some time for more information to come to help classify it. So here's an example of a family, a pedigree that if you've come to see a genetic counselor, you know about, and even if you haven't, you've usually seen. In a pedigree or a family tree, squares are men, circles are women. We generally color in things that we're interested in. So in this family, breast cancer has been colored in orange. This woman also had ovary cancer. This woman might be a new cancer patient who's wondering, why did she get breast cancer at such a young age? And we certainly use age as a criterion for thinking about genetic testing. Age, family history, clustering of the same kinds of cancer in the family, looking across the generations to see patterns. Now, there's breast cancer on this side too, and it could be just that breast cancer is a common disease, and it's certainly not always inherited. So we don't think that she had to get an altered gene from both her mother and her father to get this breast cancer. One, as I showed you before, is enough. Certainly her sister might be in a clinic like BPREP or one of the genetics clinics in your area, because there are many, where the sister might be worried, what's her risk of breast cancer if her sister had cancer so young and the family history so strong. And so one of the implications of finding out that, for example, this sister did have a variant in a gene that is responsible for her breast cancer at 32 is that other members of the family can be tested to see if they share that risk. And a lot of people come for genetic testing based on worry about the family. If someone in the family has had a positive test, having that information really helps the interpretation of the genetic test for the unaffected family member, where a negative result becomes definitive. There's a positive in the family, you didn't inherit it, you didn't inherit the risk. So this is for old people who remember Where's Waldo, but in Where's Waldo, once you knew where to find Waldo, next time you looked at the slide, you would know exactly where to look for Waldo. And basically, once you know where the mutation is, or the variant in a member of a family, you know where to look again. Now, most of the time these days, we don't look just for the alteration that was there in the family member. We usually look a little more broadly across what we call panel tests to look at least all the genes associated with breast and usually ovarian cancer risk, because we don't want to miss those. And that's partly here. And here's a woman who we think it's likely came from the dad's side, and dad can be tested too to see if that gene is present or that alteration is present. But mom had breast cancer too. Could there be something on her side as well? And we wouldn't want to miss the chance to find an important gene if it was there. So why do people get genetic testing? Well, there can be benefits. If someone has worried about risk, this can end some of the uncertainty. At least, did you or did you not inherit a risk for cancer? Doesn't, of course, end the uncertainty of when cancer might occur, but it can clarify the risk for the individual, for relatives, can help guide medical decision making, and actually for some people can relieve anxiety. Certainly, if you test negative, that's a big benefit. And even if you test positive, at least you know. Now, people have to know for themselves, are they someone who will find this anxiety inducing or anxiety reducing? And that's something that people often decide when talking to genetic counselors or friends and family or their doctors, of course. What are the risks? Well, sometimes a negative test is not definitive. So if you don't know if anyone in the family has had a variant, no one is alive to test, or no one is willing to have testing, and you test negative, you may not know for sure, and that can be anxiety provoking as well. Family dynamics. Families are no more likely to get along if they have a genetic alteration than if they don't. So you have to be careful about how family members might react and how that might influence. If someone tests positive, it usually means their parent does carry the same alteration, although not always. Sometimes people have what we call a new mutation or a de novo mutation, and they can still pass something on, but they didn't inherit it from the parent, means their siblings might not be at risk. Genetic discrimination is something that we know about now, although that has been largely dealt with at a federal level for health insurance, not for life insurance. We talk about that. And some people just don't want to know, or don't want to know now. They might not be at a place in life where this is good information they want to have. So breast cancer susceptibility genes, we used to just talk about BRCA1 and 2, and now we have other genes as well. Most of them are not just breast cancer susceptibility genes, so we have to think about some of the other cancers that can be seen with them, and the counselors can help with that. These are genes we've always said, oh, these are ovarian cancer genes, and so they are primarily, but RAD51C, D, and D do confer moderate breast cancer risk, and even BRIP1, if you have a family history, you have to be a little more careful. So we generally include the ovarian cancer genes together when we test, and we might just do a panel that looks for breast cancer genes only, or breast and ovary genes, and people can choose that. Or they might say, this is my time to look. I'd want to make sure I don't have colon cancer genes or whatever else you know about. Do the whole thing. That's another decision to be made. Now, this is not to overwhelm you with lots of data, but just to say there's been so much work now. When we started doing this more than 20 years ago, we didn't know very much. Now we know about other genes. This is a huge study, as you can see, from 64,000 women, and looking at the risk of cancer with mutations in certain of these genes. Here's just a very simplified table, but it really tells you that having an alteration in a breast cancer gene, not all genes are alike. The BRCA1 gene gives much more risk than, for example, ATM or even PALB2. And not that you can see this at all, but this just says sometimes the risk is more of one type of breast cancer than another, like a triple negative breast cancer in BRCA1 or estrogen-driven breast cancers for BRCA2, two genes that interact all the time but don't predispose to the same cancers. And this has been important work to try to sort out and make more precise the genetic work we know. And this just to remind you that I know Mary Beth Hans reminded us that there's a particularly increased risk of some of the variants in people of Jewish descent, but cancer susceptibility genes are equal opportunity problems. And you can see that actually the highest risk of carrying one of these altered genes in BRCA1 or 2, not the others, is in the Bahamas. So why that's true, we can talk about, but other countries in the world. So if there's family history, there should not be any discrimination. And yet you certainly can show that in the US, even among women diagnosed with breast cancer, that people are offered genetic testing, no surprise, more if they are Caucasian than if they are members of underrepresented minority groups. So the only other thing I'll just mention here quickly before we transition to the prevention part of the talk is that some people need to get retested. So people who were tested long ago, and yesterday I saw somebody who was tested 20 years ago. She had her BRCA1 and 2 tested, and she hadn't had cancer, but then she developed a breast cancer in the interval. So now it made more sense to test her again for the new genes. Family history can change. You didn't worry about this so much before, but then this year, unfortunately, members of the family were diagnosed. Genetic testing itself has changed. So since 2012, we've been able to more efficiently and much less expensively test for more of these genes. You know, in the early days, it was like $4,000 for BRCA1 and 2. And now we have a more comprehensive test, a more accurate test, and a test that is, I think, unlikely to change too much in the next few years. But that test is $250 maximum, and for many people is covered fully by their insurance. Guidelines change. We now test all ovarian cancer patients, all pancreatic cancer patients. And partly we do that because there are treatments for inherited forms of these cancers that work only if you have a variant. So whoever wanted to have a cancer gene variant before, but if you're diagnosed with one of these cancers, it expands the options for treatment. So we test all of those patients and can test their family members. And now tumors get genetically profiled to guide therapy, and we may test based on those results as well. So there are always going to be risks and benefits to consider. You could argue that's the same for prevention interventions, but I always like this slide because it reminds me that much of what we talk about, certainly in the BPREP clinic, but also in genetics, is the risks and benefits of exploring this information and deciding what you might do with it. Okay, let's talk about prevention. And here we're going to talk about the issues, the 3 studies, 1 in development, 2 that are currently open in the clinics, and they're not just open, all of them here, they're open at other places around the country. So I know the audience is broader than Boston. So here's the issue that we have a lot of women who could be eligible for taking something to try and reduce their risk, which is a lot of people, but certainly most people do not take anything. What proportion of people take it? So people who've had, for example, Hodgkin's disease or lymphoma, other cancers in childhood, and had radiation to the chest wall, they've already been through treatment. Maybe that makes them more likely to think about this. You can see some in the genetic mutations, LCIS and atypical hyperplasia, the things we see in BPREP, not maybe so much, although the risks are there. And then other reasons people might consider taking something to reduce their risk, 24%. What are the main reasons people don't like to take chemoprevention besides the terrible name, which we still haven't replaced with something that sounds less awful? This is not chemotherapy, but it is medication, so I guess it's chemical. Of course, the main reason is people are afraid of side effects. It's true that reducing breast cancer risk in particular has not meant that people live longer. They just get to live without breast cancer, which is not necessarily a bad thing. People don't like taking medication. They'd rather take vitamins. maybe they'd rather exercise. I hope so. They don't, I mean, lifestyle changes are hard to do, but medication, not so much. And a problem that we have is that pharma, the drug companies are not so interested in these medications because they don't make money off them. This is a study called TAM-01 or Baby TAM, and Baby TAM because it's low dose tamoxifen. So we have had data on tamoxifen since the 1990s that shows that it's a very good drug for reducing breast cancer risk, but nobody wants to take it because there are too many side effects. So the Italians, led by Andrea DeCenzi, said, well, you know, maybe the dose that you need to treat breast cancer is not the dose you need to reduce the risk. Maybe we could do quite well with a lower dose and still get the benefits without the side effects. So instead of 20 milligrams for treatment, they went to 5 milligrams for prevention, and randomized study against a placebo. So a placebo, remember, like a sugar pill, inactive. They gave it for 3 years, and they wanted to measure what happened. Did people get more breast cancer? And what they showed, so you'll now be like a professional oncologist reading these, the group that didn't take tamoxifen, the placebo group, had more breast cancers than the red line, the tamoxifen group. And they had more breast cancers in the other breast too. It wasn't just the treated breast. So tamoxifen reduced the risk of breast cancer in both breasts. The side effects, as you can see, were pretty similar. So no excess risk of uterine cancer. There was 1 compared to 0. That's not different. There was no increased risk of blood clots, the other things we worry about so much. And there were more polyps in the uterus. Those are benign but annoying. Death from breast cancer and death from other causes. Similar, no, not statistically different. So a safe intervention. Tari, I have to say, was much one of the leaders in taking up this drug and using the tamoxifen low dose. You can see that before 2019, I hope you can see, there was no red, so nobody was giving 5 milligrams of tamoxifen. But after 2019, after the study was published the first time, people started, and in this clinic, certainly people started using the medication. And the discontinuation rates just show that, you know, lots of people gave up their tamoxifen, even their raloxifene and aromatase inhibitors, the other options for postmenopausal women, but not the low-dose tamoxifen. So that has led to the development of a trial that Dr. King is co-leading with Dr. DeCenzi, who did the other work, called Baby Tears, which is a comparison of low-dose tamoxifen to a low dose of another drug, exemestane, that we use in breast cancer treatment. This is going to try to ask the question, is one of these better than the other? So we know which to offer women who have equal opportunity. You can see that to do prevention studies well, because it's not always easy to find women who are brave enough to be part of a trial, you need a lot of different centers. And so this study will be done around the world, and it's being supported by the Breast Cancer Research Foundation, which had a fundraiser here this week. A second trial, this one is already open, so the other should be open in 2024, pretty early in 2024. Now that it's funded, it can move along. The second is a trial called Crescent, which is looking at a drug called bazedoxifene and estrogen, or Duave, which is marketed for menopause symptoms and is a good drug for this purpose, a safe drug. It's been studied a lot. And I'll just try to teach you how to look at this. So this is a control, a breast, actually in a monkey, that's not being exposed to anything. It has cells and it has space. If it's exposed to estrogen, everything turns on. This is just the bazedoxifene, and this is the combination that looks a lot like everything but estrogen, because the bazedoxifene is blocking the estrogen. So women right now could consider participating in a study asking, is this a good prevention drug? It looks like it should be. They can't have BRCA1 or 2 mutations. They have to have some hot flashes. They have to be in menopause. They can't be taking other hormones. They have to have some dense tissue. They have to generally be healthy. And then, although this slide looks incredibly busy, once they're eligible based on their mammograms and their tests, they are randomized to get the medication, which is, of course, provided for free, or to wait 6 months and then get the medication, and then to measure whether this is changing some tissue in the breast in a way that looks like it would be the right direction for risk reduction or for prevention, so that if this early study works, then we could go to a larger study like the baby TAM study, that size study and that time to make a difference. This study is supported by a grant from the government. And then just briefly for women who have a BRCA1 mutation, who have a BRCA1 mutation, we have data that a molecule called rank ligand, which is hiding right in here, or rank, is part of what drives breast cancer development in BRCA1 carriers. And who knew there was a drug that blocked rank ligand? That drug is called denosumab, and it's used for treating bone loss or osteoporosis. This was work before we do any of this in humans. We always do work in animals. This was in mice, showing that if you block the rank ligand, you can stop the proliferation of breast tissue. And if you give mice this rank ligand, and these mice have a BRCA1 mutation themselves, you can delay the development of cancers. So this led to a study that's now happening around the country and in 7 countries in the world, comparing this drug, denosumab or Prolia, you might have heard of it, against placebo, where you get an injection every 6 months for 5 years. Women have to have a mutation and otherwise generally be healthy. They can be premenopausal or postmenopausal. They cannot have had mastectomies before they have participate in a project like this. They can decide during the study that they don't want to continue, they want to have mastectomies for risk reduction, and that they can certainly still do. You can see that this study is open at 34 sites around the US. And these were the sites that volunteered than that we went out looking for necessarily. The study is supported by a lot of people. The Defense Department, believe it or not, which supports breast cancer work, Amgen, who provides the denosumab and the placebo, the National Cancer Institute, and then a bunch of other groups have been very generous. And so if you have any interest in a study like this or know someone who might, there's a website and a lot of information. And although this slide, I apologize, this version is all in English. Of course, we have material in Spanish as well and access to translators for someone who might speak a different language. So that's all.
Thank you so much, Judy, highlighting some very important topics here. Again, the importance of genetic testing for women either with a breast cancer diagnosis or for women or men with strong family histories of breast and ovarian cancer. There was a question that came through in advance about if someone is adopted and don't know their family history. Yes, of course, you are still eligible, or you can still, speak with the genetics counselor about the possibility of genetic testing, even if you don't know your family history. And just quickly, there was also a question: can women with BRCA2 mutations live into their 90s or 100s? And of course, the answer is yes.
Well, first of all, people can survive cancer, but not everyone will get cancer. These cancer genes give risk of cancer, but they do not give cancer itself. And therefore, there certainly are people who have those genes all their lives, don't get cancer, and we wish we knew what they're doing that protects them. So that's another important thing to figure out.
Yes, and thank you for, again, highlighting the importance of us all working together to do these really important studies to look for new options for prevention. And as Judy mentioned, the Baby Tears, trial, we are excited to have that open, hopefully early in the new year. Again, we will certainly be, we'll let you know through our newsletters and other information when that study is available. And for the BRCA1 mutation carriers, we want to again encourage for you to reach out to Dr. Garber and her group about participating in that very important study.
Please.
So thank you, Judy.